my dear colleagues and dear friends. Cardiac tamponade PCI. Cardiac tamponade, actually after the beautiful talk by Dr. Anand, this management of tamponade and perforation almost goes hand in hand. Intra or periprocedure tamponade is a very dreaded complication. It is definitely lethal if it is left unattended. It can occur with a host of cardiac interventions ranging from coronary as well as structural interventions. And the incidence is definitely more common with complex PCIs. So when to suspect? If your patient develops an unexplained hypotension and or a chest discomfort, especially in setting of associated predisposing factors of coronary injury like elderly, frail persons, female sex, tortuous vessels, calcified vessels. Then when you are using a lot of CTO wires and all, where the wires can perforate or dissect, polymer jacket wires again have a propensity for perforation. Then when we use oversized balloons, that is balloons exceeding a 1:1 diameter, when you try to deploy oversized stents, or sometimes when your balloon ruptures, and the use of bulkier device. So all these cases you have to suspect tamponade, especially when the patient develops a hypotension. So what are the common causes of hypotension in the cath lab? Hypotension is a relatively common incident in the cath lab. It can be vaguely mediated where the response to atropine is usually brisk. It can be due to a wedging catheter where the pressure tracing, ECG changes and contrast stasis spells out what is there. It can be an associated ACS where the patient can develop angina or ECG changes. It can be because of an air embolism where a review of the angiogram can bring out the embolies. It can be due to a blood loss which can be manifest or occult, and it can be because of tamponade. Now time goes. Sometimes the tamponade can develop acutely. This usually occurs immediately within a few cardiac cycles, and it is lethal if not briskly managed, and usually it follows a catastrophic coronary rupture. It can be subacute following a wire perforation, usually develops in a few hours. It is insidious in onset, more likely to be missed because the patient will be in the ICU at the time. It can be late. I have come across a case where the patient presented with tamponade almost 2 weeks after the PCI. Rupture, say case of RCA rupture that occurred a few years back in my lab. Again, here there's a LED rupture. There's a small unexpanded segment in the LED after deploying the stent, and I tried to post-dilate, and that was the rupture. This is a case of wire perforation where the wire perforated and produced a tamponade eventually. You can see that. Now diagnosis, we have to maintain a very high index of suspicion. It can be subacute or late when it presents all classical clinical features including hypotension, pulses, paradoxes, electrical utterance, whatever it is. Echo will show a pericardial collection, distant IVC, chamber collapses, changes in the ventricular inflow velocity set. Diagnosis. Acute occurs almost always the rupture of epicardial coronary artery. Anticipate when coronary rupture is diagnosed. That is, if your coronary artery has ruptured, there is definitely a chance of tamponade. BP starts to fall. Do not waste time to establish diagnosis. Going for an LA view, watch the posterior border. If there is a positive movement, there you are. Do an echo to confirm. Here you can see that the posterior border is not moving. You can see that in a layocoidal view, the posterior border movement is quite diminished, just like stenciled appearance of the posterior border. So along with this, you will be able to see the pericardial collection because of the presence of contrast material. Subacute usually follows a wire perforation. Usually it occurs about 1 to 2 hours after the perforation and usually develops in the post-cath ICU, where the patient presents an internal hypotension, poor response to processor atropine, and with other features of tamponade. And you have to exclude concealed bleeds also. Now, how to manage, anticipate, prevent, and treat. You anticipate tamponade in high-risk situations. Prevent, use appropriate hardware. Carefully manipulate your hardware. Prompt recognition of perforation and properly treat an injured coronary artery either by balloon occlusion or embolization or covered stent or whatever it is. Now, treatment, support with fluids or pressures, pericardiocentesis, access can be, epigastric is the most common access. It can be apical, it can be parasternal. The epigastric access is the most preferred, but may be difficult in obese. Always see whether your needle reaches the pericardial space from the subxiphoid puncture. Always try to avoid multiple punctures because see, each time you are going through the left lobe of liver and the patient is already loaded with antiplatelets and all, and the chance of a peritoneal bleed is very, very high. If you have single puncture, the puncture site will be sealed by your sheath. Now we can go for an apical approach. If the pericardial approach is not feasible, you can also go in for a left parasternal approach, but there's a small risk of injury to myocardium or coronary arteries. And this is the same case that RCA rupture. You can see the collection in the pericardial space. It was treated with a covered stent along with pericardiocentesis. Now, how to do it? For a subxiphoid approach, check the needle length under fluoro, whether your needle will reach the pericardial space or not. Infiltrate local anesthesia, approach posteriorly superior towards the left shoulder, advance towards the pericardial space, delineate by contrast. Traverse the skin, rectus, left lobe of liver and diaphragm, pass a short J, arterial sheath, a pigtail over the wire, aspirate using a 3-way till dry or stable hemodynamics. Now repeat aspiration if the systolic blood pressure falls significantly or features of tamponade develop, and retain the pigtail until there is no more collection. In case of flank rupture, sometimes we may have to permit a small collection by releasing the tamponade balloon to ensure the pericardial space is being protected with a pigtail catheter. Now, covered stent. The most important problem with covered stent is limited availability. It may not be available, and there can be mismatch between the anatomy of rupture and the available stent. So, have you any option? Can you make a covered stent in the lab? Yes, sometimes you can make. At least in proximal major ruptures, you can try to make a covered stent. Choose 2 stents of appropriate size and length. Leave 1 stent undisturbed. Inflate second stent in vitro. Now deflate the balloon and harvest the scaffold. Cut away the balloon from the shaft. Trim the nose cones away to get a short plastic tube. Thread the plastic tube onto the first stent. Fold the balloon carefully along the folds. Trim the harvested free scaffold to cover the balloon over the first stent. And now you have a bilayer scaffold with a sandwiched balloon material in between. And deliver the prepared scaffold to the target over the wire. You can just see the video where it was done. The first stent, inflated. Stent is removed from the balloon. And balloon is cut away from the shaft. Cut away from the shaft. The plastic tube is harvested. It is threaded onto the second stent. Second stent. The other stitch was released, see, that is skimmed over the balloon to produce a bilayered stent with a plastic tube in between. And that was, this was done for a case of a proximal RCA perforation. It was delivered to a target site and the patient was saved. So in short, as far as PCA is concerned, Management of tamponade is actually prevention of tamponade, and if it occurs, you must be ready to tackle. Thank you. Thank you all.
Yeah. So,
Yes.
compared to the olden days, maybe 10 years or 15 years back, the older devices, bulky devices,
Yes.
non-compliant balloon, lot of issues. Now the devices are much refined. What do you think the incidence of these complications are coming less, or it is remaining same?
So I think, see, proportionately, probably the incidence is coming down. But thing is that as the number of cases increase dramatically, the absolute number is always on the increase, I think. Because I myself am having a very less number of perforations nowadays. But thing is that if the annual number is considered, maybe very high. Because the number of cases being done is far more than what was done previously.
Dr. Francis, you have something to add?
So similar one situation has been described by Japanese cardiologists, wherein over the stent they've wrapped tagada.
Yeah.
So you don't have to use a second stent to hold on to that. You just can use a tagada which is wrapped over that, and
See,
then
when
go
you
in
are
and
when
inflate.
you are in trouble, I will use whatever is available. There's no other option.
So during this era of chip, these complications are likely to happen, but only thing the awareness, recognition, and the rapid management is the only option.
Yes.
But unfortunately, we don't have any resources to train in somebody in complication. We need to study complication from others' complications.
Yes, sir. Sure.
Anyway, I think, is there any question from the audience? Otherwise, we will wind up this session. Thank you.